Morning. Interesting. Why is that not working? Why is the radio mic not working? You it? You're the only one. I'll be talking just to you. All right. Just give 1 more minute to make sure this is recording. You'll be pleased to know it's going to be short lectures today, so you can get out early. What we might do is, the first one is relatively short. The second one is a bit longer. Do you want me just to continue on and do the 2 straight on? Or do you want to have a bit of a break and then do it? So it's either you get out of here early, or otherwise there's a big break. What we'll do is we'll start the second one, stop with 10 minutes, and then have a break and then come back for the last 10, 15 minutes. But it won't go on that long, okay? First one is short. Oh, they are coming at 11, are they? Oh, okay. Okay, yeah. All right.
What is up to you?
Okay, well, I think we'll get started. So I'm now going to talk to you about tissue repair and fibrosis. And this is going to be broken up into 3 lectures. But first of all, what you need to know out of these lectures, this is general now for all 3 of them, so this is quite broad. So you'll need to understand what is the purpose of acute inflammation and how is the acute inflammatory response initiated. You need to understand the key processes of the vascular response in inflammation. Describe the different outcomes of tissue injury. Be able to review the major groups of soluble mediators and their activation and roles in inflammation, repair and fibrosis. So this covers all of the lectures. Identify differences between tissue repair, regeneration and fibrosis. And understand what processes are involved in the process of fibrogenesis, that is fibrosis. Describe the key cells and pro-fibrotic mediators, in particular, transforming growth factor beta. And then describe some current anti-fibrotic therapies and maybe new approaches to treat fibrosis. So the lecture outline then, in lecture 1, which is a shorter lecture, we're going to be talking about acute inflammation. In lecture 2, we're going to discuss tissue repair, mechanisms involved. And then lecture 3, we're going to talk about fibrosis and antifibrotic therapies. So I'm going to start by talking about the basics of inflammation. and what's involved. And I suppose a lot of this is pathology with a bit of pharmacology in it. But it's really, really important to understand the pathology, because we won't be able to understand, the mediators and how we can interfere with the fibrosis process if we don't understand how inflammation occurs, how wound healing occurs, and then the basis of fibrosis. So when we talk about inflammation, we talk about two types. Acute inflammation, which is a response of the vascularized tissues. If leukocytes and molecules of host defense from the circulation come into the sites of infection or of cell damage, whether it be, like I said, infection or whether it be injury. It needs to eliminate offending agents. It's initiated with seconds of the infection, of the injury occurring. Lasts 2 to 3 days, but it can last up to 2 to 3 weeks. It all depends on the type of injury, the type of infection. And if you're getting reinfection, for example, then you're going to get acute upon acute before it comes into a chronic phase and becomes chronic inflammation. And generally, it resolves rapidly and then leads on to the next phase, which is tissue repair. Then, of course, you've got chronic inflammation. We're not going to talk a lot about chronic inflammation, other than to just tell you a little bit about it. We're mainly going to discuss that, I suppose, when we talk about fibrosis, because I suppose it comes into the fibrotic response. So in lecture 3, we'll talk a little bit more about the chronic side of inflammation. But effectively, it's prolonged inflammation. So you get your chronic response, that abates, but if there are problems, if things don't repair, or if mechanisms are skewed and you get dysregulated healing, you could end up with prolonged inflammation, which then takes a long time to heal. In fact, it may never completely go away. And we're talking about, we've talked about autoimmune diseases and things like that. That is chronic inflammation. So there's an ongoing pathology which doesn't allow it to resolve. And you get a shift of the type of cells that you see at the site of inflammation. So you get away from your acute phase inflammatory cells, so like macrophages, neutrophils, and you get macrophages, but a different type of macrophage, what we call M2 macrophage, which I'll talk a little bit about later on. But you also get, you also get other inflammatory cells, immune cells, T and B cells accumulating, as well as you get a lot of other resident cells that come into the area as well. So it changes. And it's characterized by simultaneous destruction and healing of the tissue, and because of the inflammatory process. So it's literally a destruction, healing. It just goes on and on and on, and it doesn't resolve. Or if it does, it takes a long time to resolve. So what are the steps then in the acute inflammatory response? Well, inflammatory reaction develops through a series of sequential steps. We start off with recognition of the noxic agent that is initiating the stimulus for inflammation. So if we look here on the diagram at the top, that really is that initial stage up here, recognition. So you've got, say, microbes, you've got an epithelial barrier, you get antigen-presenting cells that will present that antigen. Macrophages come in, start engulfing things. Mast cells release their mediators. And this is the recognition by the tissue-resident sentinel cells. The second phase is recruitment of leukocytes and plasma proteins into the tissues. And this all comes via the vasculature. And so this is represented here by the vessel. You can see recruitment of leukocytes. They're able to come out of the blood vessel into the tissues. They're attracted by various different mediators that are released by the dead bacteria, for example, and also by the neutrophils and macrophages that release all these what they call chemokines to attract more and more cells into that tissue. And a lot of the proteins come out of the blood vessels into the tissues as well as more monocytes, which become macrophages, granulocytes or neutrophils and others. And you get also vasodilation to get increased permeability of that blood vessel to allow things to come out. The next stage is removal of the stimulus. So this is your macrophage that comes in and your neutrophil. They're both phagocytes. And phagocytic cells are ones that basically phagos to eat, is Latin for eating, and then these cells come in and eat the residue, eat the dead debris that's there. And they clear that area of infectious cells, for example, have died, or of dead tissue, dead cells, dead tissue, etc. So they clean it all up. And they remove the stimulus that was originally there, in which case maybe like infection, but all that is removed to allow healing to occur. And regulation of the response is really important to terminate the reaction. So here you've got, on the right, you can see you've got all your different cells that are there. You've got your fibroblasts coming in. You're now going to form granulation tissue if it's a wound injury. And that leads then to repair. But you must have the regulators to be able to allow the response to actually occur, the inflammation and the healing, but you need it to finish. And when it doesn't finish, you don't get normal repair. That's when you get things like fibrosis, which we will talk later about. And as the last stage, of course, is that repair phase. And this consists of a series of events that heal the damaged tissue. And it involves a lot of different steps, only some of which we're going to be able to discuss in these couple of lectures. So what are the inducers of acute inflammation? Well, obviously infection is the most common one that we would see. We get that on a regular basis. It could be viral infections, bacterial, parasitic, fungal. It could be across the skin, it could be breathed in. There's a lot of different ways that we can get infections, and this is one of the major inducers. And this just shows here, this is shingles. So this is the herpes simplex virus, which is reactivated to create this shingles, which is usually you get it in an older age. Generally, older people tend to get shingles. You can have it when you're young, but it tends to be older. And a lot of it is because your immune response or your immune system, as you age, is not as effective. Also, a lot of people that are on drugs, for example, on different anti-inflammatory or immune modulating drugs, are more likely to have a recurrence of this. So this is chickenpox virus that's reactivated. You can have trauma or foreign bodies. And this is an example of a foreign body in the eye. Don't know what it is. Looks like some sort of nail or something like that, but they've obviously got it in the eye, and that creates its own sort of healing. All the different types of healing are slightly different, but the mechanisms are generally the same. You can have chemical agents. And this is an example of hydrofluoric acid that someone's got on their legs, causing these massive burns. Radiation. Here's radiation on someone's hand causing blistering. You can have tissue necrosis via ischemia, something like gangrene. So we've got gangrene, which is sort of an infection as well, but what happens is that the tissue dies and becomes necrotic, and so that itself can induce an inflammatory response as well. And hypersensitivity reactions, allergies for example, asthma, they can all cause acute inflammation, and of course acute inflammation in the airways is not good, particularly if you have something like asthma, because what that induces then is with the release of the mediators you get bronchoconstriction and you can't breathe. And this just shows you hypersensitivity. So this basically is skin where someone's got hives due to some sort of rash because of maybe something they've eaten, etc., maybe allergic to. So what are the clinical signs of acute inflammation, and what are the mechanisms involved? So I'm not giving you the finger here, but effectively there's something unique that you see about this finger. It doesn't look quite right. First of all, it has redness or color. Latin is the word color. And it's nice and red because you've got, first of all, vasoconstriction that occurs, and then you get vasodilation. And when you get the vasodilation, there's more blood flow. And that's what we want. We want the blood to be able to flow so that the cells and plasma can come out of the blood into the site to help prevent the infection and heal it. We also notice that it's swollen or tumor, and, which is because of the increased vascular permeability, that the fluid comes out of the vessels into the area and it swells. What we can't see, but may be indicated by the fact it's red, is heat or rubor. And again, this is due to the initially constriction and then vasodilation. And so you've got a lot of blood flow happening really at the surface, and you've got a lot of heat being generated. And the other one that we can't see, but we can assume that it looks pretty nasty, is it's going to be very painful, and that's the Latin is dolor. And that's soluble mediators that create that pain. And what it can do, maybe it's not important if it's going to be an end of a finger like this, but if it, depending on where the inflammation is, if it's in the lung, for example, you can get loss of function. And it can, in this case, there's swelling and there's pain. And that loss of function can be very detrimental. Again, it all depends on where that inflammation occurs. So what are the key components of acute inflammation? Well, the first step is you get a vascular response. You really start off with vasoconstriction, and then pretty soon afterwards you get vasodilation. And there are endothelial cell changes, and we'll show you some examples of that. And that is endothelial changes that allow fluids to come out into the tissues. We get leukocyte extravasation. So basically that means white blood cells that are in the blood are able to escape and be attracted and collect in the area of inflammation. And then, of course, you have your cellular response, your granulocytes or neutrophils, monocytes, which are macrophages, etc., which are really important in that initial inflammatory response to help, as I mentioned before, clear up that injured site. And these are all regulated by soluble mediators, which are extremely important, some of which we will touch on today, and some of which we will discuss probably more in the second and more predominantly the third lecture. And these cellular mediators affect the vasculature and affect the blood outflow. It decreases it in terms of vasoconstriction, increases it when you get vasodilation, and that's when you get your rubor and your color, and increases when you get endothelial changes. You get increased vascular permeability, interstitial fluids and proteins collect, and that's your tumor and dolor. And of course, your granulocytes include things like neutrophils, eosinophils, basophils, and mast cells. Mast cells are really important initially for that vascular effect, which we'll talk about. And then your mononuclear cells include your monocytes and macrophages, dendritic cells, T cells, B cells, and NK cells. T and B cells do come out, but they're not the initial acute inflammatory response. They tend to be acute inflammation occurs in the first few minutes, and probably starts dying down after about 3 days. And that's when your T and B cells come in. So your immune response tends to be a little bit behind, but they still start collecting and still becoming activated. So we have a vascular response, which is one of the first things that we have. And it's the first response to a tissue injury, and it occurs within seconds. You know yourself, you whack yourself on your finger or something, you see it swell up pretty soon. And that's because of that vascular response. It initiates local tissue blood vessel responses. So that's what has to happen. The local tissue blood vessels respond to whatever the trauma is, and it sets the foundation for that cellular response, because without the blood vessels changing and allowing accumulation of cells and fluids, you're not going to get the cellular response to actually clear it up. And it's responsible for a lot of the clinical signs. The heat, the redness, the swelling is all due to, of course, the vascular response. And it involves changes to, one, blood flow, and vascular permeability, and thirdly, to cell migration. So what happens? Well, first of all, the first step is that you get venular vasoconstriction. This is a neurogenic response, and you get decreased outflow. And there's a good reason for it. You firstly do something and you want to limit the amount of damage. But then you get arterial vasodilation. So after that first constriction, again, it's a neurogenic response, you get an increase in inflow. So basically what eventually happens is that the site needs to get blood to it then to be able to start healing it. The blood thickens around that area, you get stasis, and you can get, depending on the type of injury, you can get clot formation. And you get increased vascular permeability of the vessels, which is an increased amount of interstitial fluid that builds up. And then you get endothelial cell activation, which allows, so basically the endothelial cell starts separating and you get transmigration of cells and fluid out of the vessel. So what are the clinical signs of acute inflammation with regard to the vessels? And we're talking about things like transudates, exudates, and edema. So under normal circumstances, your vessel has a balance between your internal hydrostatic pressure and your external colloidic or osmotic pressure. And effectively your plasma proteins and your cells are sitting nicely in the vessel and everything is in balance. But then after you have an injury and you've got inflammation, you get an exudate. And this exudate consists of high proteins and may contain some white and red cells. And what happens here is that blood vessel starts changing. So you can see that the endothelial cells lining the vessel, they start contracting and they open up, which increases that interendothelial space and allows cells and fluid to come out. Then you have a transudate. And a transudate is where you have an increased hydrostatic pressure inside the vessel and you get venous outflow obstruction, usually because of venous outflow obstruction builds up that pressure. Sometimes it can be a disease like congestive heart failure. And you get fluid leakage. You get a decrease in that osmotic pressure outside, a decreased protein synthesis, maybe, for example, in liver disease, and you get increased protein loss. And so what you end up with in this transudate, which comes out of the vessels, it's low in protein and has very few cells in it. Now what we really see when we're talking about classic inflammatory response is edema, which is the general term used to express, describe excessive interstitial fluid. But the edema itself is not inflammatory. But inflammation is really an exudate, and that's what we see here. And an inflammatory response is really an exudate that you see. So, what can actually induce these different effects? So, what are the origins of some of these soluble mediators which affect the acute inflammatory response? Well, there's two sources of them. The first source is a cellular source. And so these come from your cells. It comes from your macrophages, your neutrophils, etc. And there are a number of mediators which are released, and they occur in granules within your different cells. So, for example, and we'll talk about in more detail, one of the really important vasodilators are both histamine and serotonin. And these come from granules that are in mast cells, and they're released. It's also lysosomal enzymes from these cells. And it says here, so the source is mast cells, basophils, platelets, neutrophils, etc., macrophages. So some of these are already present in these cells and they're just released. And then of course others are newly synthesized once you have inflammation. And these are your prostaglandins, your leukotrienes, and things like that, nitric oxide, cytokines, etc. And all the leukocytes can make them, macrophages as well, etc. And in fact, some of them are made locally by some of the resident cells as well. And then, so that's the cellular. The other part that it can come from is the liver into the plasma. And these are your things like your coagulation or complement proteins. So here, factor 12, for example, and this activates coagulation cascade, and then eventually fibrinolysis. So when you get coagulation, you then, after a while, have to have it broken down, and you get it broken down by a fibrinolytic system. And you get complement activation, which of course is really important for killing, because we need to kill bacteria. So they use complement to do that. T cells do. So you have a cellular response and you have a liver response as the major sources of these soluble mediators that are around. So what about the cell-derived mediators? So the main ones are your arachidonic acid metabolites, and all leukocytes can make these. Second is your vasoactive amines, which comes from your mast cells and your granulocytes. Cytokines and chemokines are made by lymphocytes and your macrophages, etc. And they all are important. So arachidonic acid metabolites are from your cell membranes and your phospholipases. The vasoactive amines are usually in preformed granules that are already in your mast cells and granulocytes. And the chemokines are, of course, newly synthesized at the site usually. And so the pathway, the arachidonic acid metabolites, are things like your thromboxane, your prostaglandins, your leukotrienes, lipoxins, and resolvins. And thromboxane, its main role is a vasoconstrictor. Prostaglandins are the opposite. They're a vasodilator, and they also prevent blood clots. So effectively what you want is you want clotting initially, but you don't want clotting to keep occurring. So it's your prostaglandins which prevent that. Your leukotrienes contract smooth muscle, and they're immune regulators, and then there's others that are important as well. But very importantly are your initial proteins, mediators that come from mast cells and granulocytes for the vascular response in particular, which is your histamines and serotonins. There's lots and lots of them, but these are probably the main two, and the two that we're going to discuss. And then, of course, cytokines and chemokines. We've talked about these in some of the other lectures that we've had, and you would have heard about them. The acute phase mediators, interleukin-1 beta, for example, interleukin-6, tumor necrosis factor alpha, many, many others. And of course, we know that these are the main mediators, or some of the main mediators that are involved in different autoimmune diseases as well, and very important in chronic inflammation as well as acute. And the thromboxanes and prostaglandins is what we inhibit using steroids or non-steroidals as well. So what about histamine and serotonin? So they're released rapidly from the granules of mast cells. So these mast cells degranulate. And this just shows you what basically happens here. First of all, it's a type 1 hypersensitivity response. Its response is because of trauma, heat, and cold. It also can be activated by complement fragments, what they call anaphylactoxins. Cytokines can induce the degranulation of mast cells. Neuropeptides can. And these cause clinical effects. So, the most important thing of these is that they cause vasodilation. They're the major or most important vasodilator. They also cause smooth muscle contraction. Vascular permeability, increased vascular permeability. And serotonin, in particular, causes pain, which is a really important response. We need to have pain because that tells us that something's happening. If we burn ourselves and we don't have a pain response, then we're going to leave our hand in the fire, aren't we? So pain is very important, even though we don't like it. And eosinophil chemotaxis is really important, and that's usually a histamine response. But what I just want to show you here, so this is a mast cell. This is a transmission electron micrograph here, the one on the left. and it just shows you all the granules, these granules that sit within that mast cell. And here on the right, you've got a mature mast cell in bone marrow, and you can see these are basophilic granules which stain blue. And what happens when that to degranulate is the mast cell that's in the tissue has on its surface immunoglobulin E. And it's the allergens are attracted to IgE, and they bind to that. And that interaction between the IgE and allergen induces the degranulation of that mast cell. And then, of course, you get your vascular responses because of that. So arachidonic acid metabolites, or the eicosanoids, are really important in the inflammatory response. And this just shows you the pathway here. You don't need to learn the pathway, but know that the precursor of a lot of these, like the prostaglandins, prostacyclins, thromboxanes, etc., is arachidonic acid. And it starts off with your phospholipases in your cell membrane, which become active and convert arachidonic acid into the different metabolites, either cyclooxygenase or lipoxygenase. And from there, they can develop your prostaglandins, etc., and your leukotrienes. So the arachidonic acid metabolites come from the plasma membranes of, they're formed from the plasma membranes by the enzyme phospholipase. Key products are the prostaglandins, thromboxanes, leukotrienes, lipoxins, and these are key targets for anti-inflammatory drugs, and we do use that. So, a lot of the NSAIDs and steroids we use are actually targeting these particular pathway. It's the main pathway that we target for anti-inflammatories. Steroids inhibit phospholipase, that's how they work. And NSAIDs, non-steroidals, inhibit COX-1 and COX-2. And COX-1 and COX-2 is important, as you see here, if you took on the right, these particular genes are involved in the cyclooxygenase formation or the development from cyclooxygenase to prostaglandins. And these can be where we can inhibit. So if you can look at on the right, this diagram, you can see some crosses. I think I've highlighted them. So steroids, for example, work at that level of the phospholipases. NSAIDs inhibit COX-1 and COX-2. And we can use leukotriene receptor antagonists as well, and that inhibits the bronchospasm of the vessels. And of course we have cytokines, which are extremely important both initially and also later on. So for the cytokine response, we can have, first of all, your local inflammatory response. And cytokines, what they do is they're produced by cells in the vicinity of the injury to actually induce or increase vascular permeability by having an effect on the endothelial cells. And then, of course, endothelial cells themselves can make chemokines and make more of these inflammatory mediators to perpetuate the response. And you can see here, leukocytes, etc., are acted upon by tumor necrosis factor alpha and IL-1 beta. They become activated, and they make more of these cytokines and chemokines to attract more cells into that area of inflammation. You have your systemic pathological effect. So, for example, in the heart, the TNF that's circulating will actually cause endothelial cells and blood vessels in the heart to reduce the amount of output. It slows it down. Endothelial cells and blood vessels are acted upon, as I said, by TNF, etc., to increase permeability. And multiple tissues, the effect of these different mediators can affect things like insulin resistance. And then the systemic protective effects as well. So we need these mediators, but we don't want them to actually stay around for too long, and they can cause problems. So we control them, and the way we control them, for example, in the brain, is we can have fever. In the liver, we release acute phase proteins, and in the bone marrow, we increase the amount of leukocyte production. So what are the possible outcomes then of acute inflammation? So, and this leads on, it's very similar, I suppose, so when we talk about the outcomes of healing, because they go hand in hand. You don't usually get inflammation without subsequent healing. The amount of healing could be much smaller, but you still get healing. So if you have an injury, in case maybe an infarction or bacterial infection, etc., you have an acute inflammatory response where you have your vascular changes, neutrophil recruitment, mediators, all good and happening. Now, in an ideal world, we get resolution. Clearance of the injured stimulus, clearance of mediators and acute inflammatory cells, replacement of injured cells, and we get return of normal function. But we can have problems. We can get abscesses, etc., forming, where you have pus. And maybe it doesn't heal it quite as well as we want it to. And what happens now is that healing comes into what they call a fibrotic phase, where you start getting lots of other things being deposited. Because of all these cytokines and all these mediators at that site, it starts interfering with the normal healing process, particularly if it doesn't go away. In the case of, you may have some like an injury where something is persistent, so a foreign body type response, it doesn't go away. And so you start getting constant injury repair happening, and constant amounts of inflammation going on, and then you end up with, in this case, a fibrotic type response, which can lead to loss of function. Healing can just go straight that if there's a problem with the healing response. Or that acute inflammatory response can progress to a chronic inflammatory response, in which case healing occurs by a fibrotic healing process as well, where you don't get normal resolution, and you get what the other word for fibrosis, of course, is scarring. However, your injury may be of the type that just leads straight to chronic inflammation. So some viral infections don't go away. Chronic infections, persistent injuries, and autoimmune diseases, as we've previously discussed, they all lead to a chronic inflammatory response. Acute leads to chronic. You get angiogenesis, blood vessels growing in there, mononuclear cell infiltrates, and fibrosis or scar formation. So that's what we heal. That's how we heal in that way. So resolution is what we want. And then the inflammatory response is resolved, and everything goes back to normal. If we get chronic inflammation and fibrosis, it's unresolved. And the outcomes, therefore, of acute inflammation is either complete resolution, healing via fibrosis, progression to chronic inflammation, and abscess and ulcer formation, which I suppose is really a chronic inflammatory type response. All right, so that's completing the first lecture today, and we will continue on after now. We might have a break, given that might be some people coming at 11. I don't want them to turn up and no one's here. It just means a little bit of break. And then we'll continue on with the second part of the lecture then, which will be on tissue repair. Thank you. Hopefully. Turned everything off. I hope it doesn't keep recording. Yeah, it's a bit, now we've got sort of a 20-minute break. So